dashboard part 1, which is our performance report. I'm going to ask Claire just to lead this item before handing over to Gethin, who will then deal with the operational performance section. So thank you, Claire. I'll come to you first.
Thanks, Chair. So just noting your exhortation in the opening section that we need to remain focused on our core purpose. The IPR this month gives an update on our performance. The IPR has been updated to reflect the ministerial priorities, and so you'll see the SPC chart on page 183, 4 of 40, that does that, and that is showing encouraging movement on all of those standards. I would just note that we've had a conversation about the IPR and how that links to our overall strategy deployment, which is something that we briefed to Strategic Development Committee in October, and we'll bring back through board early next year. The cover sheet also references feedback from Welsh Government from their review of health board performance packs and the recommendations in relation to that. So taking all of that in the round, we're looking to reformat the IPR over the coming months. So certainly you'll see some changes in Q4 and certainly for 26-27. In terms of the wider scorecard, so not just the ministerial priorities, but the wider scorecard, which goes to cover our priorities as a health board, we're seeing improvement in 9 out of 16 of those metrics this month. I did just want to draw attention to the fact that we're starting to see the improvement that has been described at the board in terms of our diagnostics standard, and obviously we've already talked about 45-minute handover standard. I would just point to the balancing metric of over 12-hour waits in ED, which actually are pretty flat. And when you look at the which is an achievement. Clearly, we need to do more on that, but it is important. I think, Kath, your point earlier about how we make sure that the flow through the hospital continues. So I don't want to say any more than that, and I'll hand over to colleagues to take us through the things and problems.
Thank you, Claire. Thank you, Gethin.
Lovely. I would take the paper as read, but just draw out a few items to bring to board's attention. So in terms of our focus, we talked about handovers, and it is pleasing to see our continued performance on the 45-minute handovers. It is worth reminding board that we're running our sites on exceptionally tight margins of capacity, and any small blip in capacity does have an impact. But the teams are working exceptionally hard to try and manage out as much of that as they possibly can. And so it is pleasing to see our continued performance. We were the top performer in October. I'm hopeful that as we get to the end of November, we'll be able to continue to be the top performing health board for 45-minute handovers. We do need to remember, of course, that 45 minutes is the recommendation from the MAG, the Welsh Health Circular. It's very clear that actually the expectation is 15 minutes for handover. So whilst it is really pleasing to see the significant drop, our average handover in October was fairly close to 15 minutes, but again, there's still more work for us to do. Linking that then to the 12 hours, because of course we're managing that risk more within the hospital. It is now a focus. So I have invited support from NHS P&I to come in and do some work with us around our 12 hours and what other opportunities we've got. So Richard Bowen is working with us, and we've got some specialists from his team coming to work with our unscheduled care team just to look at what opportunities we've got on that front, ready for Q4, which they're really happy to support. I think the how then we link that to our broader pathways of care, delays equally important, and you will note in the report that sadly in October our volume of pathway care delays has gone up. I am pleased to say that now Bridgend has agreed to adopt the model that RCT had initiated regarding a straight to service model for pathway 1. So that is positive, and hopefully we can realise some of that benefit in Princess of Wales. And pleased also to say that our hospital at home capacity has really ramped up over the last 6 weeks, and we're seeing far more patients be supported out through the hospital at home model, as well as holding patients that don't need admission there as well. Just linked to that, we have had our first cut of data from the JCC regarding response time. So we've got a little bit more analysis to do, but I hopefully can bring a report in January to look at the correlation between the impact of significantly reduced delays on our forecourts around the metric of handover. But I think there are some other balancing metrics within there that we need to consider equally. From a planned care perspective, you'll note that our cancer performance in September was 64.5%. That's the highest it's been for this health board, which is great. Still a long way to go in order to get to the 75% level of delivery that we are. And for September, because it's a month further in arrears for cancer, we were the top performing health board in Wales on cancer performance. So which is positive, and you'll note in the report the downward trajectory of our own 62-week cohort, which having looked at the data for all the other health boards, isn't many of them have got an upward trajectory on this over 62. So again, confidence from P&I about grip and control on our cancer PTL. In terms of planned care, you'll note a small uplift in the volumes. It's still within our trajectory, and we have received confirmation this morning from Welsh Government of some additional funds to help de-risk our orthopaedic plan. So our over 104-week waiters sit in orthopaedics, and we've been given some additional funds to run weekend capacity to de-risk our position for delivery of no 104-week waiters by year end. Which we remain on track for. And in terms of outpatients, you'll note a significant tick up on the priority graphs around our compliance around outpatients. So this is on the back of the nationally commissioned contract, where we are seeing significant activity, normally in the region of 900 to 1,000 additional outpatients being seen every weekend across a range of specialties, and the over 52-week outpatient cohort has halved in the last few months and continues to drop by about 1,000 patients a month, which is again in line with our trajectory to have no 52-week waiters by year end. Mental health markers remain strong. The only other thing I was going to pick up was regarding stroke. So you'll note within the body of the report some metrics. So our focus has been around assimilation of the stroke unit onto the Royal Glamorgan site. As you know, there's been some challenges around workforce and other things which have stabilised, and we've seen really good recruitment and training. I'm pleased to confirm that we have got so our consultant who was on maternity leave is coming back this month, and our new appointed consultant starts in December, which again is really positive in terms of strengthening the resilience of our stroke service. There's been now a real focus on the performance aspect, and you'll note that we focused on time to CT and time to the stroke unit. And the week before last, which is the last bit of data we've got, you'll know that 50% of our stroke admissions at the Royal Glamorgan got onto the stroke unit within the 4-hour metric, which is the highest it's certainly been for for many years. So we've got a real focus now on embedding those improvements. Further focus now in Q4 around 7-day-a-week consultant ward rounds being implemented. So again, that we can meet a number of those other trajectories, but the engagement from the clinical team across the emergency department, the stroke unit, medics, nurses, therapists has been really powerful, and they are really owning and driving that forward. So that I'll stop there. Thanks, Jen.
Thank you, Catherine, for the update on the performance report on the operational side. Can I just to Becky, just in terms of the from the nursing perspective, and obviously Dom as well from a medical perspective, anything you guys want to flag in terms of some of the key headlines?
Just for IPC, we've still got a rise in C. diff and bacteremia. There's quite a lot of focus work going on there. And we've also extended our teams into the community where we've done some champion work with our care and nursing homes. So we're supporting them to try and track some of that to prevent coming in. And then the other area is around ANTT, hand washing, and we're doing some focus work around reintroducing our bundles.
Thanks, Becky. Dom.
Just very quickly, just on mortality data alone, I've just shown Karen very quickly the new spreadsheet that we've got access to in real time, which is useful. The data you're looking at is obviously going into August, that's why it's looking all really good and positive. It's in the summer months. I will say that when I come back next time, I would expect it to have a significant jump up. We've already had a reasonably high number of deaths related to flu, and that coupled with, despite our best efforts on the vaccine uptake across the area and across Wales generally, I think we're all expecting a very high mortality data across all of our health boards, very sadly. So I'll bring that to you next time, but I just want to warn you so it's not an expectation to set next time.
Thank you, Dom. Lauren, I'll come to you next. Thank you very much.
Thank you. Yeah, just briefly, within our adult mental health services, you'll see that access to psychological therapies is a challenge. But the team have listed some of the actions there that they're doing to try to increase capacity and reduce waits. Gethin's gone into detail around stroke, and obviously we get regular scrutiny within quality and safety there too. Within diagnostics, you'll see that one of the notes under sonography is around the National Imaging Academy. So the National Imaging Academy that's hosted by CTM, they're supporting the position in Wales in terms of training up of sonographers. So that will help us with our pipeline and recruitment in the future, but they'll be running training lists. So we're working with them around CTM patients as well as some of the other health boards. So there's the potential to help with some of our weights there as well. And then from an AHP perspective, we've got a good sustained position in terms of the 14-week RTT with adults and children. Audiology is also included on that slide, and that is also a challenge. But again, you can see the actions that the team are making, some of the new ways of delivering care that they're trialing to try to increase capacity.
Thank you, Lauren. Before at the end of this, obviously I'll be coming to Harold just to talk through the workforce section report. Before I do so, I know Philip, I want to come to you just in terms of the public health aspect. I know we've had an update on the annual report with 30 years and children's health, but there's also an update I asked from Philip and from Gethin as well in terms of some of the challenges around managing this year's flu season, which we've started to see, obviously with the decision to implement the use of masks across our sites. Philip, thanks.
Absolutely, no, thank you. I mean, from the report, I won't labour what you can see there. Smoking cessation is going well with 6.7% of smokers last year in CTM accessing smoking cessation services against a target of 5%. So we're doing particularly well there, and we have increased our capacity. Likewise, childhood vaccination, we're running at 89% in terms of coverage of under 5s vaccinations. That's third in Wales. Obviously, we would like to be first in Wales against the target of 95%. And there's already work underway in terms of targeting areas of low uptake, particularly in Merthyr Tydfil. Likewise, with human papillomavirus, we're second in Wales. But to move on to sort of the main event at the moment, really, our over 65s flu, the campaign is underway, which is why you can't see data on the in the report. So we're at 60.8% against a Wales average of 62.7%. We're around mid-table. What I would say is that influenza is currently circulating, especially influenza A.
Philip, before we go on, that's the uptake in the vaccine, yeah?
Yeah. But we'll go into more details now. Influenza is circulating and is increasing. I will send around the epidemiological report after the meeting. Likewise, though, with RSV and COVID-19 is decreasing. But we did see last month quite a sudden spike in terms of incidence of COVID on our population and our staff as well. We are seeing an increase in influenza cases, particularly in the Royal Glamorgan Hospital. We're currently second in Wales in terms of daily number of inpatient influenza cases in hospital. And as you can imagine, within community, we're seeing quite a number of influenza-like infections at Sentinel GP surgeries. So in terms of the canary in the mine, typically what you would see is presentations in general practice, and about 2 weeks later, you'll see that trend increase into inpatient, and a few weeks after that, you'll see it in terms of mortality. Vaccination uptake in CTM, specifically for the flu, we are essentially tracking the Welsh averages. Having said that, Merthyr Tydfil has particularly lower uptake than the rest of CTM, that's bringing our numbers down. There have been a number of changes to the vaccination process this year, and from the 1st of December, our operational team will be going out to support GP practices, areas of GP practices, to bolster the uptake of vaccination. Again, whilst we're not doing terribly in terms of 65s and older, in terms of 16 to 64-year-old in a clinical risk group, so those are people with underlying health issues, we're not divergent from the rest of Wales, but it's far below where we'd like it to be. So we're running at about 30% against 31% across Wales, and clearly we would like that far higher than that, but that is where we are. In terms of staff vaccinations, again, an interesting story. So we're running at about 42%, 40.4% in 42.8%, I apologise, against the 40.4% across Wales. Now, there's huge divergence in that. We are sort of towards the top of the pack, going down to with 42%, going down to 10% for Welsh Ambulance Service, for example, in terms of staff vaccination, which was quite surprising when you think potential vector. I won't labour it more, except to say that we are seeing a number of acute respiratory illness outbreaks within our care home settings as well, and they're being addressed. So a letter has gone out from ourselves and from Welsh Government via local authorities to care providers. But looking at the sort of modelling, actual influenza admissions are increasing and tracking on the high projection in terms of the modelling. Whereas our RSV and our COVID-19, despite seeing an initial peak, we're actually quite low down in CTM from where we are. However, the issue will be looking forward where those peaks coalesce, and so we'll have particularly acute impact on our hospitals. At the moment, the highest activity is being modelled from around the second week of December through to the second week of January, which isn't surprising, but obviously given other pressures in the hospital at the time, it's something to be aware of.
Okay, thanks for that. Philip, just really quickly in terms of, so I'll come back to questions in a moment, but just in terms of that data and tracking the more severe end of the modelling, compared to this time last year, roughly, where were we? Were we tracking the lower end last year or the sort of median?
Yeah, so last year was a relatively mild season for influenza. So this year is markedly higher. If you look at the Southern Hemisphere, they had their peak happened 5 weeks before they expected. So we had an earlier peak. and the incidence was higher. Now, there is evidence to suggest there's been a mutation with the virus, and so we're seeing some vaccine evasion. So where there isn't complete concordance between the vaccine and the circulating virus. Having said that, there is still good mapping across in terms of the effectiveness of the vaccine against the virus, and vaccination remains a safe, effective method to protect ourselves from influenza.
Thanks. Okay, we'll come back to questions. I'm sorry, I wanted to just chip in to find out exactly how that data compared to last year. How on the workforce support? Thank you.
Yes, again, assuming people have read the report, just a couple of things to highlight. So sickness, you'll know we've spoken about a couple of times. We've now launched our health and wellbeing plan, which obviously takes a broader focus than just sickness management itself, which has gone through OPC and indeed OMB from an officer perspective, and we'll continue to monitor that. We do obviously need to bear in mind that research season hasn't hit the sickness rates that you've got in front of us at the moment. That doesn't always necessarily mean that sickness rates will go up beyond, just might affect the reasons for sickness. So we'll keep an eye on that and continue to report that. Our report here is showing as red for nursing and midwifery turnover, but I think it's worth noting that the target is reset against our current 12-month baseline, which is now 5.38%. I think if you'd have said to me a few years ago you'll be in the red for having 5% nursing turnover, I probably would be quite happy with that actually. So we may need to think about how we reflect that target and whether it's meaningful. And then similarly on the percentage pay bill stuff, if our pay bill generally goes up, the proportion by definition will come down. So we may need to do some work on those too. Just more generally then on PDR and Stataman training, those continue on possibly the sort of slowest improvement trajectory ever. The graphs are very, very slightly improved over time. They're at 70% for PDR and 82% just shy of PDR, so much better than where we were. I do think perhaps in the new financial year we might want to do some specific work on both of those just to try and just on towards where we'd like to be on both of those. So targets of 85 on both of them. We're almost there on Stataman, but PDR, 30% of our people haven't had a PDR. I do think we also need to bring that data together with the staff survey data on quality and usefulness. We don't want this just to be a number chasing exercise, and we want people to have a good experience of PDR as well. So sickness is our focus very much for now, but I think we probably will in the next financial year just want to come back to those two things, not least because PDR in particular does contribute towards people's sense of well-being in work. So linked. So that's probably it from me, Jonathan.
Okay, thanks, Harold. I'll just come back to the issue of flu and the impact operationally getting. So I know there's probably a couple of things just to reflect on there.
Yeah,
Yeah,
thanks, Chair. So as Philip alluded to, we've seen the significant spike within the Royal Glamorgan Hospital. So today we've got 53 positive patients, flu positive patients in the Royal Glamorgan. We have got 4 at Princess of Wales. We're not reporting any flu positive patients at Prince Charles today. The impact of that in terms of the hospital is that all but 2 of our medical wards are closed to new admissions. So it is really tight in terms of how we're managing that, and linked to that, we're also protecting our elective pathways as well. So really focused on ensuring that we can continue to treat our elective patients. So really protecting that capacity as well. So it is creating some operational challenges, undoubtedly. We wait to see. There's an IBC cell in place, which is working through. That was one of the drivers then for mask wearing across our sites to try and reduce the risk of spread. We haven't seen yet the impact in workforce, so we will continue to monitor that on a daily basis. But it is, it clearly is a concern. We're hoping to see the numbers begin to stabilise in the next 24 hours. and beginning to de-escalate, recognising a number of those patients are coming towards their day 5 position, which is positive, but it has understandably had a real challenge for the Rotherham site over the last 72 hours, but they've managed exceptionally well during that time, and all credit to the teams, the site leadership team, to the IPC team who've worked hand in glove really to continue for the hospital to function, but manage people as safely as we possibly can.
Tom?
So just at the other scale, and I know that the RSV rates are low, but Princess of Wales have had over the last 7 days a couple of quite serious cases that children have also been transported out, being managed on the unit. So there is a slight concern there. Obviously, it hasn't come into the data exits in the last 7 days, but it might be that we're looking at something that's coming through there as well. So keep an eye on that.
Okay, questions from board members. Conscious we got a lot in the performance report, but also how we're managing the challenges of this year's flu season. Patsy, thank you.
Yeah, just a couple of quick questions. On the performance report, it's a long and very informative report with lots and lots of information, but I wonder if the stuff that has been updated since the last time boards saw this report could be in a different colour. A lot of the information in there does relate to, say, the past 2 months, but an awful lot of it is standard information that is there sort of from one quarter to the next, and I just wonder if the updates could be in red, say. It would make it much easier to read and understand. The only other question I have is, might be me not seeing it, but I can't see red release info in this report. I don't know if that's disappeared or if I'm just not looking properly.
I'll take the second point away, but in relation to the first one for Patsy, yes, I'm sure that we can do that. I think, though, your point is goes to a broader point, which is, or my broader point, which is that we need to trim down that information that we are looking at every time to be a focused number of metrics, and have the backing longer term things that don't change quarter to quarter, and that's the work that we've kicked off in terms of refreshing the IPR. But yes, for next time, let's make sure the new that'll make my life easier as well.
Thank you.
Side by side.
I'll bring Geoff in on the second point. Thanks.
Yeah, so we haven't had any immediate release declines, Patsy. I hadn't clocked that it wasn't in the report, but just to provide assurance, we haven't had any declines, and in fact we've actually had no requests for the last 3 weeks either, which is a reflection on the fact that we're not holding crews. So because we're not holding crews, they're not actually asking us to release, because our crews are automatically released anyway. So I think one of the so hopefully that's become a non-issue now because of the improved handover performance.
Excellent. All we need now is the improvement in performance, and we'll be well away.
Well, thank you, Patsy. Any questions, Simon?
Well, just some positive stuff on the flu. So on Monday we launch our new community vaccination campaign. So this is the campaign we've been working on for the last few months with members of Community Leaders Network across the three boroughs. It's really exciting stuff. This is the first time we've kind of departed from the national messaging off the back of conversations that we've had with the communities about how well that stuff lands and how people relate to that national messaging. So Monday we'll see the launch of a number of films and social media assets across the areas. We'll be sharing it through our own channels, but the key bit is we're providing those assets to members of the community, to community leaders and to groups as well, for them to share on their own channels as well. So I will share the assets. So I'm just signing them off this afternoon. I will share them with Baldo. It's a big departure for us. It's not just created by and informed by the insights and experience of people in the community, but it features people in those communities as well, because that's what people have told us will change minds. People recognising people like them, like their families, and people in the geographical areas which they feel, you know, are their homes as well. So, you know, the key thing will be, will it change? Will we see an uptick in vaccination rates? But it's certainly the right way to go.
Thanks, Simon. That's really helpful. Thank you. Rachel, I'll come to you next. Thank you.
Yes, just to congratulate Simon and the team on making all of this happen. I think this, you know, we don't know if this is going to work, this new approach, but we've got to give it a go. And I think that if nothing else, what it's demonstrated is that by working with the community, we get a huge amount of resource, intel, and I think goodwill that perhaps we've not fully, you know, realised. So, so let's see how this goes. But the feedback that I'm getting, Simon, is that you know, the community groups, the leaders that have been involved in this, are really excited about how this will work. But then, can we use this as the blueprint? So we started with pension credit, we've moved on to vaccination. You know, going back to the previous item where we talked about some of the other public health sort of health improvement work we want to do, we can just keep building on this now. So just to say, well done, and watch this space and see how it lands. Thanks.
Yeah, thanks, Rachel.
Thanks, Rachel.
Philip, just to say on the topic of the new comms materials, we've obviously been speaking with local authority leaders, and they've requested that that's shared with them. They'll put it on the front page of their websites, of their intranet, etc. And so we can really push that through.
Yeah.
So thank you very much.
Right. Okay. Any other questions to the exec team on the performance? I just have one very quickly on cancer performance. As Gethin said, getting that 0.65% is a fantastic achievement, but recognising we've got a target to get to, which is 80% by the end of March. Some of our tumour sites are routinely performing very well, and others appear to be quite stubborn in not shifting as much as we'd like them to in a positive direction. I'm just wondering, from your perspective of operation, what is it that's going to make the difference to those sites where we probably do need to see some quite significant improvement over the next 4 months?
Yeah, and I think there are some often in those areas where performance is below the level is the diagnostic complexity. What we know from our data is once we diagnose cancer, we treat the vast majority of them within 31 days. So in terms of once we've got a diagnosis, we do treat. There are two issues. One is the volume of suspected cancer referrals. So our cancer pickup rate in most of our tumour sites is in single figure percentages. So it's a big bale of straw to find the needles in. And so the amount of capacity in order to do that is a challenge, and being able to have straight test pathways when you've got that volume is sometimes challenging. So we're continuing to work on how we refine some of those pathways where straight test is possible. There are some of those tumour sites where that level of performance just isn't feasible at the moment in the way in which the pathways are designed. So if I think about prostate, because of the multitude of steps that are required in a prostate diagnosis, then it is, you have your first assessment, you then have an MRI, you then have your biopsy, because you've got to do the MRI to decide where to do the biopsy first, and then there's further, and then there's PET scanning and everything else before you even get to consideration for surgery. And then particularly for patients that are having robotic surgery, there's quite a wait to go on for that. So there is evidence elsewhere in the world around the use of AI to do hot reporting of MRs at the same time, which means that you can begin to move to one-stop shops for prostate diagnostic pathways. So all of that is being looked in, but isn't feasible within the final quarter of this year. So we are absolutely aiming to get consistently above 65% and this year, and then how we continue to develop. But it is some of these are UK-wide challenges.
Yeah, sure. That's what worth making. Thank you, Gethin. Okay, unless there are any other questions or comments, we'll obviously note the report, and thanks to the exec team for the the update, not just for the data, but also for the explanations that we've included in the report. And as I said, as Claire's alluded to, we are going to reflect on how we use the performance report in a way that just perhaps brings out and brings to life some of the key challenges that we may want to focus on getting into the next calendar year. Okay, month 7 finance update, item 6.2. Sally, thank you.
Thanks. So it's probably fair to say that month 7 was a difficult month. We saw a significant uptick in our pay expenditure, not all of which is expected to carry on, but some of which is backdating, which was not, perhaps we didn't have sufficient controls in place to allow us to forecast that earlier in the year. There are still some aspects that are subject to review in that space. So we have maintained our current in-year position, year-to-date position at 4.3 million deficit. And we are continuing to forecast break even, but I need to flag a number of risks and assumptions around that. So in terms of the critical assumptions here, is that we will receive an allocation of 28.6 million for pay awards funding for this financial year. You'll know that the pay awards have been paid, but we've not yet had funding or the funding confirmed. We are still awaiting POW roof funding as well. We've had letters that indicate that we should receive that, but it has not yet been confirmed. And you'll notice that that's moved down from 10 million to 9.1. That reflects us being transparent about the VAT recovery around the Vanguard buildings that are temporarily on our site. So we are waiting details around that. In terms of the other key assumptions that are listed here, we've identified that there'd be non-recurrent revenue allocation for the band 2 to 3 framework that has now been announced, and there has been confirmation that there will be, and I think the words are carefully written down, about Welsh Government will underwrite the cost on an actual basis. I think in reality that means we need to be in a position where we can make an accrual by year end, and I think the payment needs to be made by the end of June with an 8-week instruction window to payroll. So really we need to have all the detail as early as possible, but by the very latest in April. So that's going to be quite a challenge in terms of addressing that and making sure that we can recover all the funds as well to enable us to meet that change. But it is welcome that Welsh Government have confirmed that.
They're not going to meet the ongoing costs.
No, they're not going to meet the ongoing costs, and I'll come on to our underlying position, which has not yet been updated to reflect that. But there are costs associated with that, but we can't currently give you an estimate around that because we haven't been through the process. But we do know that there are some significant costs. And with Swansea Bay, I think their retrospective or their sort of recognition payment and in-year cost is something in the region of 9 million. And so we might expect to see something similar. So it's a material item. The other issue that is material and which we are still working through is the Welsh risk pool risk share. We know that there is pressure reported around that. The way in which that gets actioned is that our colleagues in shared services will finalise their estimates in December. And then the normal process is a top slice from our allocation, our resource allocation in January. So at this point, we're reflecting that as a risk rather than as a certainty, on the basis that we're not yet certain of the value of that resource allocation adjustment or the timing of it. Well, the timing is likely to be in January, but the extent of it. There have been figures that are moving around and mitigations are being sought, but that is a very significant issue for us in the region of 6 to 9 million at various points. But we just need to make sure that we can recognise that is a risk. And I think what I've said here is if those assumptions are not confirmed, the health board will not be able to achieve a break-even position. And then we'd need an accountable officer letter, which we've been asked to submit by the 8th of December, which would need some ratification to strategic cash support in order to meet those arrangements, but we are continuing to work that through. We've been told that the pay award funding will be confirmed for month 8. I hope that we should have, I've corresponded extensively around the roof, and we've been very, very transparent around the VAT position. I'm hoping that that will be confirmed shortly, but there remains risk within that overall position. I suppose it's worth just drawing everyone's attention to the savings position. Our current, which is on page 21 of the report. So it does assume that we will see an improved performance in savings for the remainder of the year. And we do need to improve on our current savings delivery. I think it's fair to say that at this point, we've got some significant gaps around those centrally led schemes. There may be an improvement in future years, but at this point, there's a significant gap on those ones in particular, which we filled in part with some other schemes which we've brought forward as mitigations, including some of the prescribing savings associated with category M. It is leaving us with a difficult position going into next year. So it's probably therefore just a final thing for me to highlight is the underlying position, which we're reporting as a deficit of 4.2 million, which is compared with a planned surplus of 1.7 million. So deterioration, but that largely focuses around some of the allocation adjustments we know have changed our position since then in terms of 24-25 pay award, and the position around NI where we didn't receive full funding for the costs. We need to evaluate that as we're moving forward, and whilst government colleagues have indicated there'll be significant scrutiny around that. Clearly, the savings issue will impact on that, which is why it's important that we build our recurrent savings plan. And then I suppose the other issues are things as you picked up the list, where there's a settlement where we're expected to meet those costs ourselves in future years. We need to understand that and see what it does. And there's quite a number of pay issues, including some issues around GP out of hours, and other staff groups may have an impact that will not be funded and we would need to mitigate. And I just want to put that in the context of it. We're expecting to see an early sight of the allocation matter. If it's early, on the 19th of December, there's a jobs meeting where we were and a presentation around that position. But the what's been said to date is the uplift that expected in terms of the Wales Meg will be held back for pay in terms of the allocation out to health boards, and that we will have a 0% uplift, which means all of the demand and inflationary pressures will need to be met within our current envelope. That is going to be a very, very significant challenge. And I think that leaves us with I think the words were said, there's an expectation of an investment-free plan for next year. I think even that's going to be really, really challenging given the extent of what we know around inflation, around demand, and just some of those pay issues that continue to push up costs. So happy to take questions. Cheerful as ever.
Thank you, Sally. And any questions to Sally on the data? Yeah. Thank you.
Thank you for the really comprehensive, as usual, analysis, I guess, of our funding and our finances. I guess, how do we as a board get more confidence around achieving that level of savings, sort of both in year and in future years? I know it's really, really difficult, but we are tasked as a board, aren't we, to get more assurance around how we're going to achieve our savings. And I know it's really hard, but I guess we need to ask the question, don't we, about where do we get our assurance from, and what are the plans, and what are the thoughts around all of that, you know.
So I wonder if we need, there are a range of different savings there are the centrally led schemes, which is largely where we're seeing some of the gaps, and there's the care group and directorate plans. Perhaps at ODC, next ODC, it'd be worth us having a drill down into each of those, so we can have a look at where we can see success and where we've got variation. Because whilst people might meet the overall, the initial schemes may not be delivering what people hoped.
Yeah.
So I think
that would help us with the learning, wouldn't it, about how do we build into the plan for next year. And I think we've already said, Paul, haven't we, that we're going to spend some time on the 15th that it says.
Yeah, we're going to spend a bit of time as execs talking about this. Reflecting on this year and what's worked, what hasn't worked, but also starting to think now about next year, because what we need is really plans that can start as of the 1st of April, or ideally middle of March, so that we don't have this sort of 3 months of everyone getting themselves organised. I think we also have to reflect, part of the challenge, I think, is the capacity of people to deliver, because, you know, I think about the operational people we have, you know, at least the same people that we're asking to deliver the waiting time improvements, deliver the quality improvements, deliver reducing sickness, improving staff survey uptake, digital deployments, internal comms, improving all of the things that we, you know, are really important. And then, on top of that, can you help us save, you know, X amount of millions as well? So some of this, I think we're going to challenge ourselves to say we might have to think about how we use our people in a different way moving forward, so that actually historically we obviously got a care group structure that I think works really well. I'm not saying we changed that, but for some of these big corporate schemes, we've almost got to have it's the old adage, isn't it? We've got people who are trying to change the wings on the aeroplane whilst also trying to fly the aeroplane, and sometimes you've got to have people who are sat over here doing they're not bogged down by the day-to-day stuff. They've got some capacity and time to go and help teams do some of the bigger service change. And also it reflects, I think, some of these things we're talking about are really, really big. If you think about the digital patient contact, that's a huge program of work that needs to have enough capacity of people to do not just sort of change piece, but the technical piece. And it's taken us some time, I think, to get that resource allocated and recruited to. We've got it there now, so I think it's setting us up to make some big impact. But, you know, those are the same people that will be asking you soon to help implement, you know, digital maternity or digital something else. So I just think it's this challenge of trying to prioritise our capacity on particular. But I think, you know, Sally's description of next year, it reminds us that just thinking we can make these levels of savings and efficiencies by tinkering around the edge, you know, is not going to be the way in which we're going to be able to deliver a sustainable financial model. So we're going to have to think a bit more radically, and I think we had some about how it ties in with service change plans and all those things, because some of this is going to need to be about fundamental change to maybe do our servicing as well.
Before I bring Claire Howell and Gethin in, Neil's got a question as well. Perhaps it might be useful then.
Yeah, I had two questions. I think the second question was actually Patty's question, just in terms of assurance around the savings targets. But I just wanted to check my understanding. So to get to the break-even position, we need the items on slide 4 to come through.
Yeah.
And the savings have got to come through as well. So those elements have to be true.
Yes.
Yeah. So some are in our control, some not. Slide 21 is probably more in our control than slide 4.
Yeah.
Yeah. Okay. So then I get to Patty's question, which is then, well, how do we get assurance on the stuff that we're in control of, which I guess is that last conversation.
Yeah.
Yeah. And then the challenge, of course, for next year is.
Claire?
Yes, so I was just going to reflect on what Paul was saying about there are big strategic changes and big programs that to be delivered, and having those laid out and clarity about the opportunity that those present and prioritisation of those is really important. I think we can do some of that in terms of IMTP and strategy deployment. I think that it is really important that we, linking back to some of the conversations we had earlier about behaviours and expectations, and so it's the core expectation that we run services efficiently is something that every line manager needs to hold and own, isn't it? And I think that that is often safer and more effective, isn't it? So we know that we can drive productivity out of delivering safer care, and I think how we message some of that and how we to get the kind of what I describe as the kind of hygiene factor savings, if you like, as well as the big strategic plans, I think is really important, and we should think about in our time in December.
Thanks, Howell.
Yeah, just to say really that I welcome that discussion about that further. There have been some interesting elements, both things that have worked well and things that just haven't. And we should, we should reflect on that, shouldn't we? We should move healthy to do that. And I think how we, Paul's point about how we deploy those expectations, what do we hold centrally? How does that work in our delivery arm in terms of the care groups, and how do we bring those things together more clearly? But also then when we do go off track, what's our mechanism then to pull ourselves back to where we need to be? So that, there has been some really interesting learning. There's been some good infrastructure stuff that we put in place that I'd be keen not to lose, because that, that's been good. But the delivery, as Sally quite rightly says, it hasn't been there. So we just need to reflect on that, don't we, and think about how we set ourselves up in the best way to achieve what we need to in what's going to be a really challenging financial settlement next year.
Thanks, Catherine.
Yeah, I guess just to add, first point being, it's going to be a challenging financial settlement next year, but it's going to be a challenging financial settlement probably for the next couple of years.
Yeah.
And I guess that requires us to think very differently, doesn't it? We're probably talking, I don't know, Sally, the magnitude of what, 160 million savings over 3 years, something in that ballpark.
Yes, more.
And so I think when we start thinking in that magnitude of we've got to deliver today's care for 160 million pounds less in 3 years' time, that's not going to be tweaking with existing services. So I think we have, so I guess when we think about this, we've got to think about it in a 3-year plan. And what does that look like? Recognising how do we get that magnitude of saving out, both on a non-recurrent and recurrent basis, to get us to that recurrent position. The second bit, I suppose, and it touches a little bit on Claire's point around. So I think when I think about what we were probably looking at 2 years ago in terms of where we were focusing our savings, where we are today, I think our level of intelligence around where opportunities are is better, and the really obvious stuff I think we've worked through and begun to address. The big question for us now is around that whole productivity opportunity. So and we need to be really clear on size of opportunity, ease of implementation, and so if those are the sort of the areas of focus, and we use that sort of pick chart process, that's going to help us. So if our biggest opportunity is in X, what then we need to look like in terms of our service arrangements to deliver that. That's got to be part of that discussion and that debate. And I think there's some really important pieces of work we need to do quite urgently around understanding that level of opportunity in order then to focus that plan.
Thanks, Karen.
Just a really quick point, going back to something Catherine said earlier about the research conference yesterday. It was really interesting. All the posters, all of the presentations were about developments, innovations, changes in practice. And there was a fantastic presentation about antibiotic overprescription and community pharmacists, I think, working with GPs. But these in themselves are fairly small projects. But I kept thinking, how much money have they saved by not prescribing? But it took a lot of work. So I know we all know this, but there are loads of those things. And what is not clear is how does that get taken into practice to say, we've demonstrated this, stop doing that. There was a really good thing about follow-up appointments, but how we do far too many follow-up appointments that we don't need. Let's not do that. How many people do we screen in a particular way for cancer? 95% of them are absolutely fine, but to get to 5%, and there was lots about new screening techniques. So I know we know all that, but it's just really how do we think about making that into the routine of what we do, but almost enforcing it, because we sort of try and persuade people that they might like to change their practice.
Absolutely.
Dom?
Yeah, no, that is it's a difficult problem. We've teams for years have come up with what they think is the right thing and got on and done it, and they've done the same thing for the last 10 years. Therefore, this must be the right thing. So, as we find all the time, we come to the ask, well, can we have this? This is a really good idea on top of what they already got, rather than going, well, for that is really good. What is it doing that replaces what you're currently doing? And then do that way. That's a level of maturity that I don't think we've quite managed to get to the level of. We are going to have to start. We've started. start of a year or so ago, asking those difficult questions, and that's what's starting to release some of it. But we need now at a greater level. And all the researchers are implementing all of that, because that's the latest thing that tells us the evidence behind it to do it in place. We just need to engage the clinicians more with that to understand. But there is I'm going to use getting to think of a really carrot involved.
Thanks, Dom. Sally, just in terms of really quickly on the delegated budget, and the work that is done with ODC around, how the care group budgets stack up in terms of what they're allocated, what they're now spending, and the reasons behind that. I know, having looked at where we were last year and where we are getting to this year, a chunk of what is overspent by the care groups is being offset by savings and reductions in what we are spending our non-delegated budget, which in one sense helps us to try and offset that overspend. I think it would be really useful in terms of understanding, and maybe ODC is the best place for this to happen, to understand where each care group has got to in terms of their budget allocation and what they are spending, and to understand the extent to which demand is going up and up. The fact that we are having to do more each year for our population, and that we are actually delivering to more people each year. I mean, going back to some of the data that Claire shared with me around outpatient appointments, etc. We are, as a healthcare system, we are not seeing fewer people year in, year out. I think we are seeing more people year in, year out. So it is expensive. So I think it would be good for us to articulate how we are attempting to manage that demand position, and reflect on the fact, of course, as Gethin rightly said, if you look at next year and beyond that, we are looking at a budget settlement, which is going to be beyond difficult.
Yeah, I mean, I think there's a more detailed finance report that goes to ODC that does the breakdown. It doesn't map it to demand. I suppose on a headline figure, though, we're probably not yet at the activity levels that we were pre-COVID, in terms of certainly elective care. And of course, while we are seeing productivity improvements, so you think about in orthopedics, we've talked about LHP earlier today, we're also seeing significant additional costs because the prosthesis adds significantly to that. So I think it's quite a complex picture, and I think if we reflect on some of the other public accountability meetings, we've also got a much higher head count than we did before. And I think we probably need to spend a bit of time as a board and as an exec team understanding that and what we're delivering out of that as well, because I think that's where, as we go into a difficult year for next year and beyond, it does look like it's beyond, we'll need to be clear on what we've put in place to date, what we're getting from that, and therefore what we'd expect to deliver in the future. So it is quite a complex picture that would benefit for a bit more time on it.
Yeah, sure. Thanks. I certainly appreciate all the details covered off in this report, and recognising that there's a lot of other detail that goes elsewhere to our committee as well. But I think you're right, some more detailed thinking, and particularly as we get into that, as we will be now, that process of designing our IMTP for 26 to 29. The budget plan for next year, but obviously within our next sort of planning round now. So and the fact that what we've done for this year is attempt to find investment, which we have committed to, but recognising we have to deliver the balanced plan in order to have that investment. And clearly the expectation is we'll go into next year where that will be almost impossible
will not
to do.
One of the things you can guarantee will not be acceptable will be presenting a balanced imbalance.
No.
And that is going to be the challenge, because you've always got to say that's the number, we've got to work back from that and cut our cloth. And that's quite a difficult message to give to people, because historically it's always been, well, you just not a bit for this and a bit for that. And it's a difficult message when candidly, if you're the only place that is balancing, how's that stacking up against everyone else? And I think there is a conversation we're going to have with government about this, because otherwise there is a risk that people feel that we are being almost adversely impacted for delivering financial performance. But I'm of the strong belief that at the end of the day, we've got the money we've got for our population, and we've got to try and make use of that pound for our population. Candidly, there's a bigger debate to be had, because if we think Welsh government cannot carry on putting more and more money in the health budget, of their budget into health, because there will not be any money for anything else soon. So, you know, we need to be spending money on transport, we need money on schools, we need money, because go back to our earlier point about health and well-being, there's got to be some money to spend on other things. But so I think we've got to almost try and explain to people that we have to say, this is the money we've got, we're going to just have to, and it's a tough message because but it requires us to work differently, it requires us to work smarter, it requires us to be really hard-nosed sometimes about the things we can and can't carry on doing, because I think candidly we are doing a lot of things that we could probably say, well, maybe we shouldn't be doing that anymore, and maybe there's a different way of doing it in a cost-effective way, working with a different group. I don't know. So I think it does require us to have a bit of a radical think, and in some ways it ties absolutely into the work on the clinical strategy as well, because that's going to be the strategy of how we deliver a financially stable clinical model.
Okay, I'm going to come to Dom and then finally to Sally, just to
very quickly on there. So exactly that's it. We've got to put into what is it that we have to achieve? What is the core basis that we can deliver and we can do it? Got an example here that literally came in yesterday with the Welsh Health Circular about prescribing for obesity medication, and the assumption is that we will do it within our current resources. When at the moment we can't even fund a level 1, let alone a level 2 and 3 as well. So the expectation is being put on top of us that at some point we've got to go, this is our core, this is what we can do. The rest, we're really sorry, we'd love to, but not at the moment. And that's really hard to tell to population and clinicians as well.
It is. It's a very hard message, particularly when people have the expectation that the NHS will just carry on doing exactly as people expect it to. Sally.
Yeah, and just linking back to some of what Carolyn raised earlier around policy and safety committee, in terms of seeing lots of short-term funding streams coming through. Now we will need to be, I think, more rigorous about whether we accept those funding streams if we do not believe that we can establish services in a sustainable way within the resources we're being given, because we'll need to focus around those critical elements.
Thank you, Sally. Okay, we'll note the report and we will return to this. Obviously, Sally's offered to do a bit more with the deep dive with ODC. I think, as we get into planning our budget for the next financial year, we will need to get some sessions in the diary with the board, perhaps in a board development session, just to work through, when we're clear on the finance data for next year in terms of the allocations, just to work through what that starts to look like in terms of plan. Okay, I mean, I suppose in a very similar way, just onto the IMTP and the Q2 review. There's a report from Claire for noting. I'll hand over to you, Claire. Thank you.
Yeah, thank you, Chair. I'll take report as read. Feels odd, doesn't it, to present Q2 position when we're hurtling towards the end of Q3. So an awful lot of the content of this report has already been reported through IPR or other mechanisms and has been through committee. So it's here for noting, and I'm happy to take any.
Thank you, Claire. Any questions to Claire on the update report for Q2? No, colleagues happy to send the report. Yeah, thank you, Claire. Okay, we'll move on to item 6.4, which is a capital programme update, and there's a report for noting from Sally. Thank you, Sally.
Yeah, and the report is for noting, and I'll take it as read. And I suppose it's just to identify that there's a significant programme in this financial year. It's being delivered by a small team alongside the digital team as well. The things that you'll see coming through in the next little while will be around, we've talked about LHP today. We will also be seeing the business case for ground and first floor phase 3, which will hopefully complete all the works that are required to lift the fire enforcement notice and mitigate some of the asbestos issues at Prince Charles Hospital. There's one disposal that you're aware of in terms of Pontypridd Health Centre. That sale is progressing and is expected to complete late in 2025, possibly into 2026. And those sale proceeds will go into the digital programme. And we talked earlier about the disposal of Brinkhefin Clinic, which is part of the overall land swap around Link. So I'm happy to take any questions, but you can see that we are working hard on this particular programme, which is a significant one.
Very significant. and very exciting. I mean, there are some really, phenomenal projects here. Think about the scale of what we've been delivering, in terms of Prince Charles Hospital, LHP, etc. Well, just remarkable, quite frankly. And there's some very important capital schemes here.
And actually, it's not until you see it all written down.
Yeah.
You really I mean, we all know about these things in individual places, but when you see it all written down, you appreciate just the scale. So the first thing is that, great job that the capital and the estates team are doing to deliver all this, because it's a big challenge keeping it on track. But I think there's also something for me about, in like the conversation you've just thought about the money, is how do we communicate to people that we are still investing in the facilities and things for the future. So I think, Simon, maybe there's something about maybe how everyone hears about the big schemes, but there's actually a lot of other things that are going on in other areas that people, unless you're directly working in that area, you might not realise. So I just wonder whether we do a bit of a feature on a regular basis about showing people what's happening in different locations in terms of improvement. Just because I think there's something about highlighting there is a lot.
I think for staff, but externally as well. I think that's what we're talking about doing with Bridgend, isn't it? Having a bit of a kind of a focus on trying to regain the narrative on the social media channels within each area. So absolutely.
Okay, unless there are any questions to Sally on the capital update report, colleagues happy to note the report. Thank you. 6.5, the Welsh Language Standards Annual Performance Report, and I'd like to welcome Ben to the board, fellow Ben, and this report is for approval. Thank you very much. Thanks, Ben.
Diolch yn fawr iawn, gyfer y gwahoddiad y bwrdd yma heddi. Thank you very much for the opportunity to be here this afternoon, I should say. To start off this morning, or this afternoon, I should say, around the Welsh Language Annual Report. So you can see on the screen there, the Welsh Language and Culture Dashboard, which I think the purpose of that is to structure the report today and reporting going forward. So I'd like to talk through that this morning. So the focus here is really hone in on what those outcomes need to be for Welsh language, and as I said, to structure reporting going forward. How each one is measured on there is explained in the annual report in the appendix, but just to give one example, the measure there around, for example, the interest on learning Welsh and staff to then come forward would just be proportion of our staff who've learned Welsh as a proportion of those that have showed an interest, so 81%, which is a really high measure. But as I said, each metric is explained in the report. So that is the baseline data there for this year. It was created last operational year. So what that means is that going forward now we should see an increase in those figures each year. We did do a 6-month review of that dashboard last week. So I'm happy to say that most of those figures have indeed risen. So we've already got progress baked in there. But just to go through each one this morning. So in terms of skills development, we've had a really good year in terms of learning Welsh and CTM, and we've had over 200 members of staff actually step into learning Welsh at work. Which is an incredible number, and actually a 233% increase on last year, where it was only 60. Important to note there, that's been possible by a partnership working with the University of South Wales and New Welsh Glamorgan, who really supported us by our strategic delivery plan for that, and we really managed to get staff on those courses. Just to note as well that we are evaluating that scheme, and we've had some really strong increases in use of Welsh, for example, in the memory assessment service in Mithrican, in the paediatric speech and language services, and also within health visiting as well, really showing the increase in Welsh with patients and also with each other, crucially as well. So it's been a really impactful thing to happen this year, as I said, by partnership working. And we are using the Kirkpatrick 4 levels model there to evaluate that. To turn to recruitment then as well, last operational year was an excellent year for that. We really stepped into that space quite strongly as a health board. Welsh language skills have been included within the people plan, which is excellent to really give it that strategic emphasis as well as a health board. Over 90% of our recruitment material is being published bilingually from 0% the previous operational year, which is quite an achievement for the health board. In terms of the vacancies that we publish, again, really important last year that we managed to publish a decision tree tool, which allows managers to objectively assess how each vacancy needs to be advertised. So, for example, should it be published as Welsh language skills are essential, desirable, needs to be learned, but no skill needed. The legal requirement is that those vacancies are assessed individually by an objectively recorded assessment, and we are now able to do that, I'm pleased to say, which is an excellent step forward. We have put training in place as well to support managers to use it this operational year. It's more of a two-way conversation as well around ensuring the manager has opportunity to feed back to us as well and have that two-way discussion on any concerns and queries. And what the evaluation has shown so far is that like going through that training, manager anxiety does decrease quite significantly. So really important step forward there. In terms of a look ahead, so as is noted in the report as well, we are reporting high assurance on 60% of the Welsh Language Standards regulations, which is an excellent place to be, I think. But that does mean we are in breach of 40%, so just to balance that with that. There has been an increase in 2% overall in that compliance, which doesn't sound a lot, but I think two things. To be compliant with 60% is really high. We are a really complex organisation, so I would absolutely take it with me. But also, it's a robust figure that's evidence-based, so we can be really confident in that figure. It doesn't go up unless we have the evidence for it to go up, I think, which is a good thing. And the governance is really strong around it. So we are currently working through this operational plan, just to kind of focus on that as well. So we are doing some targeted work to improve the completion rates of equality and Welsh language impact assessment, so addressing both governance arrangements, but also ensuring that we've done our homework as well and to make sure managers can be fully supported on that. They are a really, really important tool or methodology, if you like, to make sure that we are plugged in fully into the work that's happening across the organisation. We do have a Welsh Language Steering Group that has to continue to meet, but we are going to be reviewing and revising our governance model for Welsh language matters as well to ensure we have the right people on that group going forward with the right level of accountability to, if you like, blast through the final 50%, the final hurdle. I think it's a good way of putting it. So there will be an advocacy space for champions, but we do need further strengthening of that group a little bit. We are going to be responding to a formal order in January from the Welsh Language Commissioner. So again, excellent to go back with 60% compliance. Excellent, we've got the evidence base for that, but just to focus as well on that final push now where we aren't. But what I would say is just to refer back to that dashboard. As I said, progress on all of them is baked in. So we've got some real wins in CTM, some real progress being made there on really core things to make a difference. So as I said, recruitment and learning Welsh at work. Those aren't easy things to have sorted, so we do need to take the win there. And the final point I would make as well from me is that it really is a pleasure to work with our staff. We have some brilliant staff working here, and to do this job, honestly, is a privilege. So, diolch yn fawr.
Thank you very much.
Diolch cadeirydd, diolch yn fawr iawn I Ben, mae'n good I gweithio gyda ti. Thanks, Chair. Thanks, Ben. It's really great to work with you. So I've been chairing the Welsh Language Steering Group over the last year, and I think Ben's already sort of pointed out some of the progress that we've made. And I would say that this isn't just recognising our own organisation, but the Welsh Language Commission themselves as well. Ben and I had a really encouraging meeting with the Welsh Language Commissioner, staff and Welsh Government colleagues a couple of weeks ago. And Cwmcarth Mechanic is now being recognised as sort of leading the way in some of these areas. I think that's really commendable to Ben and the team, and the kind of positive approach and energy he brings across the organisation. I also was aware that the Welsh Language Commissioner's Good Practice Awards were last week up in Wrexham. Again, CTM took away an award from that. Some of the work we've been doing on introducing Welsh to some of our whiteboards that Welsh speaking inpatients are able to use. And that's work that Ben's taken forward with digital colleagues and with nursing staff as well. So again, it's that collegiate approach. The Welsh language isn't just for Ben, Abby and his team, it's for everyone within the organisation. So I take that as a real positive. And some of the work that Ben's also done with our Inspire programme and kind of our management development with George and Howell's team as well. And he was able to showcase that at a national event in Conrindale Wells last month as well. And again, you know, it was great to see how many people from other health organisations and social care organisations coming to speak to Ben and George to learn from how we're embedding this in our own organisation. I think Ben's also pointed out that we've still got some work to do in this. We don't rest on our laurels. I think we've made real progress over the last 12 months, and really looking forward to consolidating and taking that forward to Ben over the next year as well.
Yeah. Kevin?
Yeah, diolch Ben, and I've really great to see the level of improvement that you just reported, which is fantastic. I attended leadership board on Tuesday for Paul, and the Welsh Language Commissioner was doing a presentation there, and clear that their focus is on standard 110, which is the ability to have consultations in Welsh. And I guess there's something about, you know, I know we tried to do a number of things on that, and I guess it's how we push that further and harder within CTM. And linked to that then was I guess a bit of a question for me about how we support primary care as well. So I think there's absolutely our responsibility of the people that work for us, but equally we commission primary care services, and how do we begin to support them and reach out to primary care to think about the expansion of all of this learning and how we support them with our products to being able to increase the number of consultations in general practice with Welsh as well. So it'd be good to catch up afterwards on that.
Sounds good. Yeah, no, I must say diolch to Ben for all the hard work. I know, as Gareth said, I think it's a small team, and to have achieved all that you've achieved, as well as all the requests that are coming. The downside for you guys is the more everyone knows about you, the more people want to use your services for things like translation, and then puts more pressure on. But I think it's a really important part of what we do, and I guess just reiterating what Gareth Getkin was just saying there. I guess there is just something about then. How do we take this to the next level in terms of particularly around the way in which we interact with patients? And if you've got Welsh speaking patients who are first language Welsh speakers, they should be offered the opportunity to have a consultation. Now, of course, there's going to be challenges if we don't have a Welsh speaker in that particular specialty or in that particular subspecialty area. But I'm just thinking about our digital systems and how are we flagging that people are a preference for a Welsh language consultation. It adds complications in the way we manage things like waiting lists and things like that. But at the end, I think we've got to work that through. So I think for me, looking into the coming year, that's probably going to be one of our biggest areas of focus. But I know you've got some good clinical colleagues as well who are interested in that space and are looking to try and grow the number of consultations in Welsh, which I think is positive as well. So that's really helpful. So thank you.
Yeah, I think you can hear from that how all of these things meet together. So our recruitment plans, our skills plans, all of those things. And there's a really detailed plan that sits behind that standard 110, isn't there? That's linked in the main paper with your actions or whatever. And you can just see how all of these things hang together. But I know I just want to repeat really the comments about how fortunate we are to have Ben in this space, and thank him for approach and the delivery in this space, because I think the shift approach has been such a change for us in terms of trying to make this a much more positive agenda. You don't, with all due respect to sort of lawyers in the room, you don't always excite people by quoting the law at them, apart from maybe Helen.
That was a good ending.
This worked out. The sort of shift in approach that I think has been really positive. So thank you.
Thank you, Alex. Any questions to Ben on the report? Excellent report. I mean, phenomenal to see this being brought to life and the way you conveyed those messages around the data. Absolutely fantastic to see it. And again, just to echo the thanks to the board for what you're doing and the team. But to see that we are advancing this agenda the way that we are in CTM really is absolutely fantastic. It's the right thing to do. Yeah, absolutely.
It's amazing the progress that we made over the past few years. I remember the first Welsh language report, which wasn't quite as exciting as this one. So yeah, you've got to congratulate him and Ben and his team on the way it's been moved forward. And I like the hearts and minds argument, Ben.
Absolutely right. No, I'm with you to this. And you set a standard now, Ben. We need to see this the reports. Ben, thank you very much indeed. I'm Lord, happy to approve the report. I'm guessing we are. Yes, thank you very much. Thank you. Much appreciated. Thank you. Okay. We're going to move on to item 7 this afternoon. And apologies, we are running slightly over in this meeting, but we've been covering some very important matters in today's meetings. We always do, but I didn't want to curtail the discussion. Strategic planning section, 2 items here. The first is the planning together the winter preparedness operational plan for 2025-26. Getting, thank you.
Yeah, no, thank you, Chair. And I think you've got the paper in the pack, so I don't intend to talk to it verbatim, but every year we prepare a winter plan, which is factored on 2 things: one, learning from the previous year, what worked well, what didn't work, and then more importantly around what is the forecast and how we build the public health forecasting in, and also then those things that are advised from Welsh Government. Clearly our main focus is actually building that level of resilience in all our business as usual work. So it isn't about just having a process in place for winter. It is about us having a process that is robust and can respond to the additional pressures that we see during the winter period. I think examples of that is we've now got a really good integrated escalation policy. We've got really clear standard operating procedures in place across a whole range of areas, inclusive of boarding, of ambulance handovers, and we're really seeing the benefit of those in the way the teams are working. So as we as we head into winter, what's the additionality we're doing? So plans on our sites for de-escalation of capacity. So we have a really clear plan for each of our acute sites and our community sites on the level of capacity that we will be closing down in preparation for this period, and that always testing time early January. We also have had a real focus this year on working with our local authority partners, and so not only have we got a CTM wide plan of action, we've now got individual action plans for each of our localities. So again, some very specific work, and we were having a conversation about this with local authority colleagues, and I think there is a real consensus that operational join up is the best it's been. So I think that is whilst there are challenges, the fact that we've got those processes in place is really positive. Local authorities were given across Wales were given an extra 30 million, and so we've been really trying to ensure that where that additional capacity is brought on, it is absolutely about supporting those areas. Paul's touched on it, but we were issued this week with the letter setting out the 2-week reset. So for the middle 2 weeks of December, there'll be a Wales-wide process, which is absolutely, again, about really trying to create the space capacity as we head into winter. And as Philip has alluded to, our current tracking of flu is concerning, and therefore our ability, we want to get our hospitals in as good a state as we possibly can heading into that period. Also, you'll notice that we've got clear plans against the 6 Welsh Government action. So there's some specific focus on things like our high-risk respiratory patients and how we're using some technology to support those. So I'm thrilled that we've really adopted the use of national available product, and actually we've probably grabbed 80% of the capacity of that for CTM. We're the only health board that's really embraced that, and so we are onboarding our high-risk respiratory patients to that service. The other thing that is going to be different this winter to previous winters is we've got a 7-day-a-week cover from our infection prevention control team. So again, really specialist advice to help the site teams, to help the on-call directors to make the right risk-based decisions. We've already seen the benefits of that coming through. Also within the pack, then you've got detailed care group plans on how they're managing that, and also our resilience plans for winter weather. So we do one of the big pieces is keeping our sites open, keeping access to our sites, and how we pull that through. So I guess in terms of just flagging the key risks for board as we head into winter, flu is clearly probably our biggest risk, and the severity of that within our population, but also then the how we manage the onward capacity with to continue to have a good flow and make the benefits of those improved relationships with our local authority colleagues. But I'll close there and take any questions.
Thanks, Gethin, and thank you for what was such a comprehensive plan and many moving parts, which is really important, bearing in mind the complexity of what we tend to face this time of year. Any questions to get on the plan? Any observations? Neil, thank you. I
just had a question. I was going through, and I can't judge whether 16 beds is enough or not. There's an awful lot of detail in here around how much additional capacity is being planned, so I can't assess that. But I was just trying to get a sense of what's the learnings from last year that have come through that have said that 16 beds is a sufficient amount or not a sufficient amount. So
So we've done a lot of bed modelling with members of Stu's team. So we Andrew Nelson, we've done all of that, and it's a little bit difficult this year. Of course, last winter we had the challenge of POW, and of course we had services in different places, and so we didn't have the same flexibility across all of our sites. This winter we go back to a little bit more normal in terms of that available range of service. So it does make life. It's made some of that planning assumptions a little bit difficult, but that's where the numbers are suggesting we need to be working.
As you say, a very comprehensive plan. Of it, yeah. The level of detail is quite significant. So,
Kathy.
Yeah, so echo that. It's clearly a really comprehensive plan built on learning from last year. And what also comes through is it's multi-agency.
Yeah.
And it's looking at the whole flow from preventing, looking at how do we stop people getting flu, how do we stop them coming through to hospital, and and then looking at people coming in hospital, homes, and they're brilliant. So and I assume there's a load of relationships in there to achieve that. So can we leverage those relationships to bring in the public health, the bigger picture, the more strategic picture? Because clearly there's really good relationships in there to achieve this.
Yeah. Yeah, no, absolutely, and this has been sort of managed in part with the RPB, so this has also gone through RPB, and clearly that's where a lot of our local authority colleagues sit. We and more broadly then with PSB and everything else. But Claire might want to come in as well.
Well, just to say that a plan is a plan, isn't it? And the reality is that when things fall out of the parameters of that plan, it's the relationships that you fall back on and the way in which we work together. And I'm meeting with with colleagues from local authorities about all of this routinely and accounting for government budget.
Thanks. So
I'm just going to touch on the comms and engagement piece. I think this year, and partly due to kind of additional capacity we brought on, we've got much more work going on the preemptive comms and messaging around winter as well. So there's a lot of content gathering that's been going on for the last month or so, and we'll carry on into December as well, working with colleagues in primary care, acute mental health, and public health as well, just to make sure we've got a really good library of messages to share both internally and externally, because we can sometimes struggle when the heat is on in the winter to get really good kind of spokespeople and really good messaging as well. So we're in a far more resilient place than we've been in previous years on the comm stuff.
thanks, Simon. That's really good to know. Okay, well, thanks to the team for the amount of work that's gone into this, and I really appreciate the challenge. It's challenging in any winter, but the complexity of what we've seen thus far with the flu season and the next few weeks, and maybe as I've said, as you're modelling things from mid-December to mid-January, it's going to be more intensive. So those communication points are really important, but also that shared endeavour with our colleagues in local government and elsewhere, and how this plan then aligns with the work they are doing, I'm guessing, in social care as well. So the plan is for endorsing. So if I'm going to ask the board to endorse the operational plan before us. Thank you very much indeed. Moving on to item 7.2, Countries and Health Park, the outline business case for phase 2, which is the regional arthroplasty facility.
Yes. So I'll do. Yeah. No, that's me. That's me.
He's ready to go.
I'm ready.
And a very warm welcome back to the board as well to Rosie, our program director, here supporting this.
So again, very cognizant. We've had a detailed briefing earlier in last week around this. So I'll we'll try and keep this brief, recognising we're significantly over time. Just to set a little context, regional orthopaedics, we've been working as a Southeast region now for several years on how do we move to a sustainable model of orthopaedic delivery. A large amount of effort with support from NHS P&I, looking at what is our recurrent demand and capacity gap within orthopaedics, and unsurprisingly, the data is clear. You've seen this at board where we've got a significant demand and capacity shortfall in a number of the subspecialties, and what you're about to see in terms of LHP is the regional solution for the demand and capacity gap in lower limbs. So this demand and capacity gap we've worked through, where there is real opportunity for greater efficiency across all three health boards in terms of how they use their existing capacity. Are we meeting all the necessary standards and evidence base to deliver that, both in terms of the productivity, the operating list, but also target length of stay? Even with all of those assumptions, there is still a recurrent shortfall of 3 operating theatres worth of demand within the South East Wales region. When you think about what our growth assumptions will be over the next few years, as well as our existing demand profile, and so as a region, then we have developed the proposal for a orthopaedic hub as part of the Flanders Health Park development, and that will be to deliver that closed gap. Just for, in terms of the assumption within the outline business case, just to be explicit, we have assumed a lift and shift of our current inpatient orthopaedic facility, which is currently in Princess of Wales, into Flanders Health Park. And therefore the current budget for that has been assumed within the financial case. Potentially, as we look more regionally then at the solution for hands, shoulder surgery, foot and ankle surgery, there might be further changes within that. But for the purposes of the outline business case, we've just assumed a straight lift and shift of our inpatient service into LHP, which is 3 theatres, and the additionality of then the other 3 theatres to close the D&C gap, and therefore that is the model that is being built. I'll hand over to Rosie to quickly canter through some of the capital pieces, and then we'll pick up the revenue piece and go from there.
Thanks. Thank you, Rosie. Thank you.
Thank you. Okay, so I think given Gethin's comprehensive overview on the strategic case, we can probably just, before we go past this one, I just want to give assurance to everybody in terms of the strategic case, the design, the clinical methodology behind that design. The LHP team have undertaken a wide amount of learning. That's been in terms of visits and learning from exemplar units through setting networks and discussions. So what we have worked on is an evidence-based practice. We visited places like Exeter, where this model is already in operation, as well as heading to Colchester, who have recently finished an 8-theatre unit, who actually are being built by the same contractor that we have just appointed. So those are just a headline, and the OBC contains a vast amount of detail on a lot of the learning that has been taken on board in developing this phase of LHP and the surgical hub. So if we could just move on again, as Gethin has just pointed out, there's been a considerable amount of demand and capacity work undertaken, unsurprisingly indicating a shortfall in capacity. And as Gethin has pointed out, that's led us to a 6-theatre unit, with the initial planning assumption at this phase of 3 transferring from CTM in. As there will be a second phase of the orthopaedic plan, which will support the full business case, where this will be examined and expanded further. And so if we just move on to the case itself, the OBC, without wanting to go into too much detail, is supposed to be a bit of an overarching option appraisal. It's a little bit limited, you'll note, in this case, and that's mainly because there are so many givens already. We own the site, we've had sign off to the original scope, we've got a main contractor already on board, so we've made considerable progress early on. So that means that we just undertook a basic option appraisal to prove that the development is worth doing, that what it gives us is a social value and a benefit over and above not making this development. So it justifies it justifies the expenditure and shows that the overall we're going to have a benefit from the investment, taking into account a raft of patient and staffing and capacity benefits as well. The key headlines, I suppose, in the OBC are going to be capital and revenue costs. At the moment, the capital costs are based on a forecast. Design is at a relatively early stage, what we call the Royal Institute of British Architects stage 2. There's a massive amount of work to be done over the next 2 to 3 months to bring that up to the same level as phase 1. So the forecast cost at the moment, 124 million. Considerable amount of that relates to equipment, which under phase 1 is being provided by the ISP. So that there are some differences why, there are some reasons why we have a higher cost on this one. It has been benchmarked with other units and it comes out as a reasonable cost per square metre. This will change from OBC to FBC, as you'll have seen earlier in phase 1, but we are confident that this remains a reasonable forecast for the site, for the costs that we are facing. We are expecting to complete in late autumn, early winter 2028, subject to all business case approvals going in line with our current programme. It's about a 2-year build programme. In terms of the revenue, I think Gethin's already pointed out, we have undertaken some workforce planning, identifying the levels of workforce that will be required to run this, taking account of best practice and other evidence. We have considerable non-pay costs for this unit. That's because we are looking at an increase in activity in line again with getting right first time guidance. The prosthesis costs are significant for this, so any increase does give us a higher non-pay cost for this specialty. So we're looking at circa £40 million cost with the transfer of some resource related to the CTM theatres and government funding for depreciation. That does give us a regional gap or regional additional revenue cost of 29 million. However, if we were to look on the next slide, I think again the important benchmark is we need the demand and capacity has proved we need to provide this activity. If we were to look at doing it via an English tariff or again via private outsourcing, we would incur considerably higher costs. So in terms of the best use of the resource, the best way of delivering the extra activity, it is best done and offers a value for money solution to be delivered through LHP. So if we can move on, this is just to give assurance on the governance structure. Apologies, you won't be able to read it, but it's just to prove the number of work streams we've got and how we're feeding into and out of the regional programmes, as well as maintaining our own structure. So for this OBC, we are asking the board to approve the submission of this OBC to Welsh Government, and also that we are enabled to complete and tender the design to develop the FBC. There will be an overlap between OBC approval and us undertaking work to be ready for the FBC. So basically it means we keep working to provide assurance we have Welsh Government capital coverage to undertake that work. The OBC itself is only requesting an extra £1.6 million funding. That's to get us to an FBC, which we are expecting to come to May boards. The actual balance of funding will be requested in the FBC. We are looking again at having a solution that comes towards in May. So throughout January to April, we will be focusing on a raft of work to get us to a full business case. So if we can just move on, then I think I've probably covered off most of the next steps. So again, as per phase 1, this is going through all 3 regional boards for approval. And our event was yesterday, Cardiff is also today. We are aiming to get this into Welsh Government after a bit of tailing again on the 5th of December. And this will also go to IIB on the 15th of January. This is a specially convened Welsh Government Infrastructure Investment Board. They generally happen at the end of the month, but with the impending election, this has been brought forward to enable approvals to be made within a window that they are permitted to be. If all of this complied with, we will be bringing an FBC back in May. And we'll be aiming for a late June investment board there. And this could see us starting on site in August 26. Obviously, our contractor will already be on site working on phase 1, so the mobilisation window is quite small. It's a 2-year build. We would hope to see works completed by September 28. I just wanted to outline there will be some key pieces of work for the FBC. The most central element of that will be the regional orthopaedic plan phase 2, which is likely to run in tandem with the FBC in terms of its publication. So that's all I was planning on saying. Happy to take any questions.
So if I just add, so clearly the revenue consequences is significant, and the proportion of that currently modelled for CTM is greater than just one additional theatre's worth of cost. And the reason for that is by using our existing capacity more efficiently and more effectively, we're expecting to see a ramp up in the amount of hip and knee replacements we do. So we're already seeing this year that by moving to a single unit at Princess of Wales, where we've historically done about 500 to 600 joints a year, we're tracking towards 1,000 for this year, because we're getting much better productivity on our theatres. The revenue cost is the revenue. The staff cost is the staff cost. The issue that's driving then that additional uplift for us at CTM is the cost of the prosthetics. As a region, I think we recognise that whilst it is really good value for money in terms of that assessment, there is we've just been discussing the financial uncertainty, the financial challenge of the next few years. We recognise that we're going to have to respond to this, but there is probably a discussion we're going to have with the Welsh Government around the overall national support in order to deliver this level of additional activity in line with those ministerial requirements. So I think I don't think it's to underplay that this is a significant increase in proposed spend from our existing budgets, and therefore we are going to have to think through a route in which we seek some additional support for that.
Thank you. Again, Paul.
Yeah, I agree what Catherine's just said, and I think the question we've got to ask ourselves is, if we don't do this, we're sitting here in 3 years' time with never increasing waiting lists going up and up and up and up, and Welsh Government throwing ad hoc monies at us to outsource and solve the problem in the short term way, which is what we've done today, frankly, of short term solving problems, which is fine, but we need a long-term sustainable solution, and that is, as this shows, is going to cost us money. I suppose getting to something about the prosthetic, actually, when we look at it, we're going to spend more on prostheses than we are on staff. So I just wonder whether, as a region, and I know there's some procurement work going on, but this does feel to me like an area where we should be having some sort of partnership dialogue with some of these suppliers, because there are people out there that would give their right hand to be a strategic supplier to a regional centre, the first of which in Wales, etc. There's quite a lot of kudos that comes with that. So I'm just, if I'm honest, I'm not sure sometimes that we're that clever in our procurement of more strategic relationships of that nature. And I just wonder how we might think about that, approaching that. And I know we've had conversations previously with Life Sciences Hub and others about this sort of agenda, but I just wonder whether there's something we could do on that, because that might help mitigate. I'm not saying it will eliminate the cost, but it might certainly help drive a better price joy.
So absolutely, and that work is underway. So we are working both as a region and nationally. There is a real clear intent to move to 2 hips and 2 knees, and that we would own. And therefore we've got a different scale. We've done quite a lot of rationalisation within CTM over the last few years, which is good. But although we haven't, one of the oddities about having a shared service is we are all buying the same product at different unit prices, which sort of seems a little odd. But part of that work is very much to move to a and how we potentially partner, because of course there are there are opportunities out with the immediate supply of prosthetics. About, there are a number of orthopaedic units across the bridge that are partnered with suppliers that provide a whole raft of other support.
Dom.
Yes, so it's partly really what we get sort of said is actually CTM we're doing quite well. We've gone with two and a bit providers, and to be fair, the bit is when we have unusual cases we bring a second company. Across Wales, though, there is huge variation within those what those two suppliers are. So it's trying to work and align that. The Wales network is trying to lead on this to try and create two suppliers for the whole of Wales, two needs, but it's, as you can imagine, difficult to get everyone to agree to that. But I think certainly regionally, it's something we have to be working to. What we do in LHB is these are the two main suppliers we've got, and then the civil costs come with that. All right, shouldn't be difficult to do some respect.
Any questions to Gethin or to Rosie on the request that's in front of us today to approve the OBC of CAP?
It's more of a comment, really. So thank you for all the work that's gone on in it, and we had a bit of a chat about it yesterday, didn't we? Just to help on understanding, and I think it's absolutely the right thing to do. But I absolutely second around needing the national support for the revenue costs, because when we're looking at a long-term financial strategy, it's going to be really, really tough. It's the right thing to do. It's going to give us more services and better services, so we've got to do it. But I suppose the question is more around workforce planning and the assurance around that, I suppose. I don't know where I'm looking. Is that how?
I mean, there's a lot of work going on already on the
Yeah.
I mean, what I would say is there's a lot of concern about workforce. You build a centre like this, we're not going to struggle to recruit.
No.
So I'm a bit. I get it. I get what people worry about, but there's a lot of noise about where's it going to come from. Well, we will find people who will want to come work in a brand new dedicated orthopaedic centre, whether they be surgeons, anaesthetists, scrub staff. But there is an opportunity which is being looked at through the work of what different types of roles could we develop. It doesn't have to be like for like lift and shift of what we currently do in one theatre already today in either Cardiff or here or wherever into a new centre. It gives the opportunity to relook at roles, different types of jobs, apprenticeships, all these sorts of things, which I know Sharon and others in the care group about how.
So all of those things, and digital, we need to maximise the digital opportunities as well. But I guess I agree with you on all of what you said. But sorry, you're right. And then the only other bit I was just going to say is we're very, very heavily linked in with Cardiff and Vale, and they be colleagues, because obviously not destabilising the regional workforce is one of the principles of the work that we're doing. So, but all of that is being considered at the same time. Workforce is always a challenge, right? But we're across that. We've got a plan, and we continue to work with the team just to monitor that plan as we go through.
Just on the workforce question, it's worth noting that one of the work we've done with Colchester is that they established that as a new additional unit, and that they had fully recruited, and I think recognising that recruitment in England is not as positive as it is in Wales in terms of vacancies. So if you look at their current vacancy rate to our vacancy rate, they're in a less positive position. And they recruited, they trained a bespoke workforce to work in that facility. So I think it is.
Well, that's the other thing to say is this model will only work if we've got people working to standardised pathways that we designed. So it's not about taking. We're very clear that we're still operating as we're running units, so like people moving through the unit, and the people that work in there have got to appreciate that is how it works. And if you don't want to sign up to that, well, then that's perhaps not the right place for you to come and work. So the whole premise of this is about throughput, and all the evidence tells you if you have a facility that's well designed with people with the right skill set and the right motivations, they will deliver big productivity improvement and good quality care, and it makes it an attractive place for people to come. But it won't be for everybody, and that's fine because we've got plenty of other places for people to work as well. So absolutely.
Well, and Hull's touched on it, but actually this is an area where collectively across South East Wales as well, we know we can do better actually in terms of our current digital provision. So huge opportunity to maximise new advanced technologies and how we do that collectively together, and it's part of the basis for our regional digital data workshop next week.
Thanks, Stu. And yet again, you know, despite all the challenges our healthcare system faces, and this is a response to the challenge around our demand and capacity, this is an extremely exciting project. You know, hopefully the first of what could be a number of regional diagnostic and treatment centres in Wales, and you know, something here for not just for us, but also, you know, to provide that possibility, that scope, that capacity for both Cardiff and the Vale and our environmental one as well. So yeah, as a regional solution, this is absolutely where we should be. So thank you to Gethin, and thanks to Rosie's presentation, and just to echo Kat's thanks to the entire team for, again, the enormity. I mean, it is a huge project. A lot of work goes into this, and it is one part of a number of different OBCs and FBCs that we are getting to support the delivery of this whole project. So